So let us discuss about middle cerebral artery infarction today. So this is the circle of Willis which we discussed in the last video as well. So these are the two vertebral arteries which are combining to form the basilar artery, which are dividing into the two posterior cerebral arteries, right, constituting the posterior circulation. This is the internal carotid artery which is giving off anterior cerebral arteries, the middle cerebral arteries, and the posterior communicating artery which is connecting the anterior and the posterior circulation together, forming the circle of Willis, right. So we need to focus on this middle cerebral artery today. So this is the artery we need to focus on in today. So we can see that the middle cerebral artery is going via the Sylvian fissure in this area. Let us trace this artery. So this is the middle cerebral artery which is going via this pathway, right, and continuing on the lateral surface of the brain. So this part which is supplying the deeper structures of the brain via the lenticulostriate branches is known as the M1 segment of the middle cerebral artery, and the part which is continuing on the lateral surface of the brain and dividing into the superior and the inferior division is known as the M2 segment of the middle cerebral artery. Now what if there is a occlusion of these arteries? So let us try to understand this via this diagram. So this is the M1 segment which is giving off these lenticulostriate branches which is supplying this very important area of the brain which is known as the internal capsule. So if there is an internal capsule lesion, we know that this area contains densely packed fibers containing the corticospinal tract representing areas of face, upper limb, lower limb. So if this part is involved, there would be contralateral dense hemiplegia. This is very important and characteristic of internal capsule lesion, that there would be involvement of upper limb, lower limb and face of the contralateral side. Apart from this globus pallidus and putamen can also get involved, and there can be movement disorders like hemibilismus or Parkinson like movements can also be seen rarely in a M1 segment infarction. So this was all about M1 segment occlusion, which was manifest as an internal capsule lesion with contralateral dense hemiplegia and hemibilismus and Parkinson like movement disorders sometimes, right, rarely. Now this artery is continuing and is dividing into superior and inferior division on the lateral surface of the brain. So let us see what if there is a occlusion of this branch, this M2 branch. So this is traced here, the superior division and the inferior division. So the superior division is supplying, see this artery, middle cerebral artery combined is supplying predominant almost entire area of the lateral surface of the cerebrum. So the superior division, if we see, this is the central sulcus, this is the motor area and this is the sensory area, which have a representation of upper limb, face, right, because lower limb we knew that it got represented on the medial part of the cerebrum, right, medial surface of the cerebrum. So what if there is a occlusion of the superior division? So there would be contralateral weakness and sensory loss of upper limb and face. Next, there is an area known as the frontal eye field here. The role of the frontal eye field to cause a conjugate deviation of eyes towards the opposite side, right. So if there is a frontal eye field lesion, it will cause gaze preference towards the same side or the side of the lesion, because eyes cannot move towards the opposite side, right. So side of lesion there would be gaze preference, right. Next, there is area which is carrying the superior optic radiations or the Bohm's loop, so which will result in a contralateral inferior quadranopia. So these three features would happen whether it is a dominant lobe or a non-dominant lobe lesion. Now what are the extra things what would happen if it is a dominant lobe, right? So there is a representation of Broca's area as well. So there would be Broca's aphasia, and this is the angular gyrus, which if involved would result in the Gertzmann syndrome, which would manifest in the form of right-left confusion, difficulty in calculation known as dyscalculia, difficulty in writing known as dysgraphia, difficulty in reading known as dyslexia, and there would be finger agnosia, which is patient would know that these are fingers, but he would not be able to name them, like middle finger, ring finger, he would not be able to tell like this. So these are two additional features apart from these three features which are seen if there is a lesion in the dominant lobe, dominant side of the superior division of middle cerebral artery, right, affecting the dominant lobe. What if the lesion is affecting the non-dominant side? Then apart from these three features, the extra features which are seen in the non-dominant side are hemi-neglect, then apraxias. Apraxias is not able to perform a learned skillful movement, like dressing apraxia, constructional apraxia, right? So these are the things which are seen when there is a involvement of the non-dominant side. Now what if this inferior division gets occluded? Then only few things are seen. Number one is Wernicke's aphasia, if it is a dominant side, and number two, on either side the Mayer's loop, the inferior optic radiations are there, so there would be contralateral superior quadranopia, right? So these are the things which are seen when there is a occlusion of the M2 branch of the middle cerebral artery. So M1 syndrome we discussed, lenticulostriate vessel would be affected, so there would be contralateral dense hemiplegia. Globus pallidus and putamen can get affected and can result in Parkinsonism and hemiparesis, rarely, right? M2 syndrome, superior division in the dominant side would cause contralateral motor and sensory deficit of face and upper limb. Frontal eye field would be gone, so gaze preference towards the same side. Contralateral inferior quadranopia would be there, right? Apart from that, two additional features, Broca's aphasia and Gertzmann syndrome would be there on the dominant lobe. In the non-dominant lobe, apart from the three things, there would be constructional apraxia, dressing apraxia, and hemi-neglect would be there, right? And in the inferior division, there would be Wernicke's aphasia and contralateral superior quadranopia would be there, right? Now, what if there is a complete MCA infarction? So a complete MCA infarction would manifest as a combination of all these features. So there would be contralateral weakness with global aphasia, right? So combination of both Broca's aphasia, Wernicke's aphasia together with all other findings that we discussed would constitute a complete MCA infarct. So the next step, we get a stroke protocol done. So this is a T1 weighted imaging showing hypo intensity in the MCA distribution, right? The T2 imaging showing hyper intensity, but again the problem with these T1 and T2 weighting images are can be normal up to 6 hours. So we get additional sequences like the DWI and ADC done in a stroke protocol, which are showing us a DWI and ADC mismatch, that is a hyper intensity on a DWI and a hypo intensity on an ADC, confirming that this is an acute ischemic stroke and thus the patient is eligible for thrombolysis, right? And this is a CT scan which is showing a hypodensity in the same MCA distribution. So these changes comes much later than the MRI changes. After 1 to 3 days of a stroke, the changes start coming on CT scan. So this was all about MCA territory infarction. Thank you.